1, 2,
And review, somebody female.
Oh shit, almost got some blood going. Oh, he's wearing it too.
You're in the bay. Once you get over to the bed, we'll give you the story. Everything's going to happen super fast. Welcome to the emergency room.
I lost the pulse.
It's charter book.
300 please.
I'll keep your card again.
Pulse check. No pulse.
No more pulse.
Yeah. Here, what are the echo people get? And her blood pressure is off the dropping.
45 minutes of CPR and no return of circulation. Okay.
Hey guys, in this particular episode, we're going to be talking about shock. Now, shock in the ER is huge, especially in trauma or even on the medicine side of the ER. It's huge. It is a huge portion of your concern, and it will definitely guide your care. Now, I know that we kind of briefly touch on it here in nursing school, but at least in the emergency room and potentially the ICU, shock is a huge component of your care. And I do not believe that nursing schools or the programs dedicate enough time to shock, because like I said, shock is a huge, huge portion in the ER. So you have 5 types of shock. Now, the school might tell you 4, but you have 5. You have obstructive shock. That right there is like when you have a pneumothorax, and it kind of pushes the trachea over, and it can, it can obstruct the inferior superior vena cava, and you're not going to get blood flow the way you need it to. And so it's considered obstructive shock. And then you have cardiogenic shock. That's when the heart isn't getting enough blood, and you're going to see that typically with your ACS or your acute coronary syndrome or your heart attacks. And then you have your distributive shock, which is going to be sepsis. And you have neurogenic shock, and that's the one that they don't really talk a lot about. But you have neurogenic shock, and then you have hypovolemic shock, which is where a lot of programs really focus in on is the hypovolemic shock, because that will kill you faster than the other ones will. Just because the nature of, if you're just pouring blood out onto the floor and you don't stop it, that's it. So in the ER, we deal with all of the shocks, right? We deal with all of them. But in the trauma side of the world, definitely hypovolemic shock is going to be your main concern. And then on the medicine side, it's going to be distributive shock or septic shock. Now, neurogenic shock and septic shock are going to present vastly different than the rest of the other shocks, than the other 3. Okay. Compensated distributive shock or compensated septic shock is the shock that will look the most different. And it is completely opposite of everything that shock tells you. So with shock, traditional hypovolemic, obstructive, or cardiogenic shock, you're going to get pale, clammy, sweaty, depending on like what's going on, your heart rate and your blood pressure will kind of do these weird things. But the main presentation that you're able to physically see is going to be cold, clammy skin and loss of color. However, on distributive shock and compensated distributive shock or septic shock in the early stages of it, it will look completely different than that. Your patient is going to be warm, dry, hot to the touch, and they're going to look red. Even if they are darker skin complexion, I took care of a guy that was a Black American, and he came in and he was kind of on the darker side of life, and he was in septic shock because he had this decubitus ulcer that hasn't been tended to. And under his skin tone, you can clearly see the redness, in his skin color. And then when you touched him, he was warm, like he was just sitting outside for like an hour or two, in the summer heat, and his skin was dry, so that's going to be distributive shock. It will present differently than the other shocks. Now, neurogenic shock is a life-threatening condition, and it is when there's an injury or insult to either the spinal cord or the brain, okay? And so it will present in such a way that that your heart rate will drop and your blood pressure will drop. Now, the crazy thing is that if you have a head injury and you present with neurogenic shock and you got that heart rate that dropped, and then you have this, blood pressure that dropped, the mechanism of injury, right, doesn't really dictate like what's going to happen. However, like if you have this insult to the brain, okay, and it's no longer able to regulate your heart rate and your blood pressure, right? That's the reasoning why you have a low heart rate in neurogenic shock, right? And then if it is an injury or insult to the brain itself, as it starts to swell, you're going to develop this Cushing's triad, okay? And Cushing's triad, you already have the low heart rate, okay? But what you're going to start to see is you're going to start to see your pulse pressure start to widen, okay? So your diastolic number will drop and your systolic number will rise, and that will cause this widening pulse pressure, okay? That's two prongs of the Cushing's triad. And then the last one is going to be irregular respirations, maybe like an agonal breathing or maybe grunting, snoring, whatever, right? So something's going to indicate that you're going to take their air away, okay? So those are your 5 types of shock. I know that a lot of nursing schools and a lot of programs will tell you there's 4, but there's 5. Cardiogenic, obstructive, distributive, hypovolemic, and neurogenic, okay? And like I said, remember with distributive shock, aka septic shock, you're going to present differently than the rest of the shocks, okay? You're going to present warm, dry, hot, okay? That's what you're physically going to see. So I just wanted to touch on that before the episode gets started. But again, guys, thank you for listening and enjoy the episode.
Usually when we talk about a medical diagnosis, there is this expectation of precision. It feels almost like engineering,
Right, yeah. Very binary.
Exactly. Binary. Like someone breaks their arm, the x-ray shows that jagged white line, and the clinician just points at the screen and says, well, there it is. Broken or not broken, it's clean.
But the moment you step into the intensive care unit and hear the word shock, that diagnostic certainty just completely vanishes.
It totally does. We are suddenly operating in murky waters.
Yeah.
Because shock isn't just about, a low blood pressure reading flashing red on a monitor.
No, not at all. It is the absolute opposite of a binary diagnosis. At its core, shock is life-threatening cellular starvation.
Right.
We are looking at a fundamental imbalance between the oxygen the cells demand to survive and, the oxygen the body can actually deliver at the microcirculatory level.
So everything else we see at the bedside, the tachycardia, the altered mentation, the failing kidneys.
All of it. It's just downstream noise from that initial microscopic starvation.
And that is exactly what we are unpacking today. If you are working at the bedside, managing drips, and evaluating hemodynamics, this deep dive is for you.
We're going to aggressively apply the 80-20 rule today.
Right. To master the pathophysiology and the bedside management of shock, cirrhose, and MOD, we really want to look past those superficial vital signs,
Understand the timeline of how cells die, how organ systems collapse in a totally predictable sequence, and most importantly, where you can intervene to stop that cascade.
But to get ahead of that cascade, we first have to understand the universal failing physiology that runs in the background of all shock states.
Yeah, before we look at specific triggers, we have to look at the baseline mechanism of cellular death.
I've always conceptualized this, the body's baseline response to shock, like a major city experiencing a massive sudden drop in water pressure.
Oh, that's a good way to look at it.
Right. Because to keep the absolute most critical infrastructure functioning, like the hospital and the downtown financial district, which are your heart and your brain, the city makes a calculated decision.
To just cut off water to the suburbs.
Exactly. The skin, the gut, the kidneys, they just go dry. They are sacrificed for the greater good. But the fascinating and frankly terrifying clinical question is, how long can those suburbs survive without water before the rot spreading from them causes the whole city to collapse anyway?
That analogy perfectly captures the systemic shunting mechanism. Because when that trigger happens and hypoperfusion sets in, those cells in the suburbs, they are forced to switch gears.
From aerobic to anaerobic.
Yes. From highly efficient aerobic metabolism to a desperate, incredibly inefficient anaerobic metabolism, just to, keep the lights on.
And the byproduct of that desperate anaerobic shift is lactic acid. It just starts pooling in the tissues.
Right, because there isn't enough oxygen or perfusion to carry it away, or to even allow the liver to clear it.
Which brings us to the progression of how this actually looks on a timeline. In the initial stage, this is happening purely at the cellular level.
Exactly. You have anaerobic metabolism and lactate buildup. But clinically, if you're looking at the patient in the bed, you might not see any obvious hemodynamic changes yet.
So it's silent?
Mostly, yes. The real shift happens when we enter the compensatory stage.
That's when the suburbs actually lose their water. The baroreceptors in the carotid and aortic bodies sense that drop and stretch, and they just sound the systemic alarm.
And the sympathetic nervous system floods the body with epinephrine and norepinephrine. You get massive systemic vasoconstriction.
The kidneys panic too, right? Because their perfusion pressure drops, so they fire off the RAAS cascade, holding onto every single drop of sodium and water they can find.
The clinical reality of that compensatory stage is that the body is desperately trying to maintain MAP, arterial pressure, by artificially cranking up the SVR.
Systemic vascular resistance.
Right. Blood is aggressively shunted away from the lungs, the gut, the skin, and the kidneys. But, compensation can only last so long.
Right. If we don't fix the underlying supply and demand mismatch, the patient slips into the progressive stage.
And that's when the capillaries themselves begin to fail. Vascular permeability increases, and fluid just dumps out of the intravascular space straight into the interstitial space. We start seeing systemic edema.
And crucially, that is when you start to see mental status changes. The brain is no longer being perfectly protected by that shunting mechanism.
So if you are watching your patient, the red flags of this deterioration are really clear.
Worsening mentation, a sudden drop in urine output as the kidneys take a hit.
A rising lactate alongside a widening base deficit, say anything greater than -6, and a narrowing pulse pressure.
If those are trending the wrong way, your patient is basically circling the drain toward the refractory stage.
Yeah, profound hypotension, hypoxemia, and just massive accumulation of metabolic waste like ammonia and CO2. At that point, the organ failure is unrecoverable.
So recognizing those early cellular starvation alarms is what really separates a good clinician from an elite one. You have to intervene while the city is still just shutting off water to the suburbs.
Not after the buildings have already burned down.
Exactly. So let's take that universal foundation and apply it to the specific mechanisms of failure. We've established how cells starve when flow stops, but what happens when the actual volume, the fluid itself, is simply gone?
That brings us to hypovolemic shock, the empty tank.
Now, we know there's a difference between absolute hypovolemia, like a massive GI bleed or trauma hemorrhage, and relative hypovolemia, where the fluid is third spacing from severe burns or a ruptured spleen.
Right.
But from a purely physiological standpoint, does the body care where the fluid went?
The cardiovascular system doesn't care at all. It only knows that venous return is plummeted. Because the volume is gone, preload drops significantly.
And without preload, stroke volume falls.
And cardiac output tanks right along with it.
Yeah.
The end result is profound cellular hypoxia.
When you walk into the room, this patient looks exactly like someone whose sympathetic nervous system is screaming.
They're anxious, tachycardic, tachypneic.
Their skin is cool and clammy because all the surface vessels are totally clamped down.
And if you have a pulmonary artery catheter in place, the numbers tell a very specific story. You'll see a rock-bottom CVP and PAWP because the tank is empty, combined with an incredibly high SVR.
Because that high SVR is the body's desperate attempt to squeeze whatever tiny volume remains up to the brain and heart. It's clamping the pipes.
Exactly. So the immediate bedside priority is establishing massive access, 2 large-bore IVs, 14 to 16 gauge or an IO, and aggressively replacing what was lost.
We're talking about the 3-to-1 rule here, right? 3 milliliters of isotonic crystalloid for every 1 milliliter of estimated blood loss.
Yes. And we have to be really thoughtful about our fluid choices here. Dumping massive amounts of normal saline isn't a benign intervention.
Right. It heavily risks hyperchloremic metabolic acidosis.
Exactly. And reaching for lactated ringers might be standard, but if that patient has concomitant liver failure, their liver can't convert the lactate to bicarbonate.
Which just confuses your clinical picture and makes their acidosis even worse.
We also have to constantly evaluate if our fluid resuscitation is actually working. We are watching for improving neurostatus and rebounding urine output.
But at the bedside, utilizing a passive leg raise challenge, that gives us real-time hemodynamic feedback. By raising the legs 45 degrees, we are essentially auto-transfusing the patient with their own venous reserve.
If their cardiac output or stroke volume improves on the monitor, we know their heart is still fluid responsive. If we don't aggressively correct this volume deficit, the tissue destruction from failed autoregulation becomes entirely irreversible.
So if we pull the 80-20 rule on hypovolemic shock, boiling it down to 5 things to remember.
Number 1, the core patho. Decreased intravascular volume lowers preload and cardiac output.
Number 2, key finding. Tachycardia with high SVR and low CVP.
3, most dangerous complication is irreversible tissue destruction from failed autoregulation.
4, priority nursing action. 2 large bore IVs and a rapid fluid replacement.
And 5, most important treatment, the 3-to-1 crystalloid replacement or blood products.
So in one sentence, if you see an anxious, tachycardic patient with cool, clammy skin and dropping urine output after trauma,
Think hypovolemic shock and do a massive fluid resuscitation with a passive leg raise challenge to check responsiveness.
perfect. So fixing an empty tank is relatively straightforward mechanically. You find the leak, you fill the tank, you monitor the response.
Right.
But it's almost more terrifying at the bedside when you have a completely full tank, but the pump itself is dying. Let's look at cardiogenic shock.
This requires a completely different mindset. Cardiogenic shock is the leading cause of death following an acute MI. The myocardium has sustained such severe damage or is under such profound depression that systolic dysfunction just sets in.
The heart simply cannot pump the blood forward.
No, it can't.
Now, wait, I have to push back here because this is where bedside instincts can actually be super dangerous. If a patient's blood pressure is tanking, the reflexive habit for a lot of clinicians is to immediately hang a fluid bolus. We want to increase preload to increase pressure. Why is that such a fatal move in cardiogenic shock?
Because the heart is already failing to manage the preload it currently has. If you rapidly bolus fluid into a patient with a failing left ventricle, that fluid has literally nowhere to go but backward.
It backs up into the pulmonary circulation.
Yes, pulmonary pressures skyrocket, fluid leaks into the alveoli, and you quite literally drown your patient in their own bed with severe pulmonary edema.
Wow. The assessment picture changes drastically because of that backup. You still have the hypotension and the tachycardia, but the pulse pressure is dangerously narrowed.
And the hallmark respiratory finding is crackles on auscultation, accompanied by a rising oxygen demand.
Hemodynamically, it's basically the inverse of hypovolemia in the lungs. You have a high pulpemia because of the pulmonary backup. You still have a high SVR from compensatory clamping, but your cardiac output is dismal.
Often less than 4 liters a minute. High cardiac biomarkers, too.
Right. So the interventions here pivot entirely away from volume expansion and focus heavily on manipulating the mechanics of the heart.
We utilize vasodilators like nitroglycerin to deliberately decrease both preload and afterload. We are trying to remove the resistance the tired heart has to pump against.
Simultaneously, we use inotropes like dobutamine to increase myocardial contractility.
Essentially whipping the tired horse to get a little more forward flow while balancing the risk of increasing myocardial oxygen demand.
And if pharmacology isn't enough, we escalate to mechanical support. An intra-aortic balloon pump or a ventricular assist device to literally do the work for the left ventricle.
Just bridging them until they can get to the cath lab for definitive revascularization.
And the warning signs that you are losing this battle.
A continuously rising PAWP, worsening crackles spreading up the lung fields, and complete cardiovascular collapse.
Okay, let's hit our 5 things for cardiogenic shock.
1. Core patho. Pump failure leads to low forward flow and pulmonary backup.
2. Key finding. Hypotension with narrowed pulse pressure and lung crackles.
3. Most dangerous complication. Complete cardiovascular collapse and death.
4. Priority nursing action. Administer O2, prep for inotropes and vasodilators, and absolutely avoid fluid overload.
And 5. Most important treatment. Revascularization in the cath lab and reducing afterload.
So one sentence picture. If you see hypotension, a high PAWP, and crackles,
Think cardiogenic shock, and do prep for intertrophic support and afterload reduction holding large fluid boluses.
Got it. So we've seen the mechanics of the empty tank and the broken pump. The third major category feels, well, entirely different at the bedside because the volume and the pump are usually adequate, initially at least.
But the vascular bed itself fails.
Right, distributive shock. I think of this like taking a standard garden hose and suddenly swapping it out for a massive, heavy-duty fire hose. You have the exact same volume of water flowing from the spigot, but because the diameter of the hose is suddenly so massive, the water just trickles out at the end.
The pressure is gone.
This category covers sepsis, neurogenic, and anaphylactic shock. Let's start with the heaviest hitter in the ICU, septic shock. But walk me through this. Why does a patient's skin feel warm and flushed in early sepsis when every other shock state we've discussed leaves the patient freezing and clammy?
It comes down to the mechanism of the vasodilation. Sepsis is an exaggerated, chaotic immune response to a microorganism. The body releases a flood of pro-inflammatory cytokines like TNF and interleukin-1,
Which cause massive endothelial damage.
resulting in profound systemic vasodilation and increased capillary permeability.
So they dilate, they leak, and they form microthrombi in the capillaries.
Exactly. So to answer your question of the warm skin, in early sepsis, the massive vasodilation creates a hyperdynamic state. The heart is actually pumping harder to compensate, so cardiac output might be normal or even elevated, but the SVR is profoundly low.
So the warm blood is pooling in those massively dilated surface vessels.
Yes, and it isn't until later when the compensatory mechanisms totally fail and microvascular obstruction sets in that they become cool and mottled.
The bedside management of sepsis is just a race against the clock. The hour one bundle dictates our priorities.
We immediately measure a lactate level to gauge the severity of cellular starvation.
We obtain blood cultures before doing anything else to isolate the pathogen, and then we hit them with broad-spectrum antibiotics and a rapid fluid resuscitation of 30 millokilograms of crystalloids to fill that suddenly massive vascular space.
And if they remain hypotensive, despite that aggressive fluid loading, like if their MAP refuses to stay above 65, we have to artificially squeeze the pipes.
Norepinephrine is our absolute first-line vasopressor here.
We might add a low dose of vasopressin to assist, but we aren't titrating vasopressin. It's just a steady infusion to help restore vascular tone.
We see that same massive dilation in neurogenic shock, but the trigger is mechanical rather than infectious. A spinal cord injury, typically at or above T5, severs the communication pathways of the sympathetic nervous system.
And the loss of that sympathetic vasoconstrictor tone leaves the venous and arterial beds massively dilated. But what makes neurogenic shock so distinct at the bedside is the heart rate.
Because the sympathetic nervous system is knocked out, the parasympathetic nervous system is running the show completely unopposed.
So instead of the tachycardia we see in every other shock state, this patient presents with profound hypotension combined with bradycardia.
It's a bizarre clinical picture the first time you see it.
It really is. They also exhibit poikilothermia, taking on the ambient temperature of the room because their thermoregulation is completely offline.
And since this isn't a fluid loss issue, dumping massive amounts of fluid isn't the primary fix. We reach for phenylephrine to directly squeeze the peripheral vasculature and atropine to manage the symptomatic bradycardia, all while keeping the spine stabilized.
Right, and then the final distributive state is anaphylaxis. A severe hypersensitivity reaction triggers massive histamine release. The timeline here is terrifyingly fast.
You get sudden vasodilation, rapid capillary leak, and severe bronchospasm. The airway swells shut while the blood pressure bottoms out.
The only priority here is stopping the histamine cascade and reversing the bronchospasm, which means administering IM or IV epinephrine immediately, followed by fluid resuscitation, antihistamines, and bronchodilators.
Okay, let's do the 5 things for distributive shock overall.
1. Core pathio is massive loss of vascular tone or permeability.
2. Key finding. Sepsis is warm skin early. Neurogenic is hypotension plus bradycardia. And anaphylactic is stridor or wheezing.
3. Most dangerous complication is microvasculature obstruction and ARDS, specifically in sepsis.
4. Priority nursing action. For septic, it's the hour 1 bundle. Anaphylactic is epinephrine. Neurogenic is stabilized spine and give atropine.
5. Most important treatment. Norepinephrine and fluids in sepsis to maintain MAP greater than 65.
1 sentence picture. If you see suspected infection, persistent hypotension despite a fluid bolus, and lactate greater than 2.
Think septic shock, and do start norepinephrine to target MAP greater than 65 while finishing the hour 1 bundle.
Before we get into the final, darkest cascade of the ICU, we should briefly touch on obstructive shock. The hemodynamics can look confusing, but the mechanism is purely mechanical.
Right, this is a physical blockade, a cardiac tamponade, a massive pulmonary embolism, or a tension pneumothorax.
The heart is healthy and wants to pump, the volume is there, but a physical obstruction is literally preventing the heart from filling or from ejecting the blood.
The cardiac output drops precipitously, while the afterload remains high. A classic assessment finding you might catch at the bedside is jugular venous distension, as the blood simply has nowhere to go and backs up into the venous system.
And pushing vasopressors or inotropes isn't going to fix a fissity barrier?
No. The treatment requires rapid mechanical decompression, pericardiocentesis, a needle decompression for the pneumothorax, or an embolectomy.
Okay, this brings us to the intensivists' endgame. We hear the terms SIRS and MLDS constantly on the unit. Systemic inflammatory response syndrome and multiple organ dysfunction syndrome. How does the body transition from trying to fight off an isolated insult to systematically destroying its own organ systems?
The transition from SIRS to MODS is essentially a controlled burn turning into a wildfire. SIRS isn't just triggered by sepsis. It can be ignited by severe mechanical trauma, prolonged ischemia, or massive burns.
It's an unchecked, generalized inflammatory response happening remote from the initial site of injury.
And those inflammatory mediators cause diffuse endothelial damage and microvascular thrombosis everywhere. When that systemic inflammation causes 2 or more organ systems to actively fail, we cross the threshold into MODS.
Which carries a staggering mortality rate of 40 to 60%.
Yeah. And the sequence of how the organs fail is remarkably consistent. The lungs almost always take the first hit.
Because the widespread endothelial damage causes fluid to leak directly into the alveoli.
Right, surfactant production drops, the alveoli collapse, and the patient develops ARDS. You watch their PF ratio steadily decline, and they inevitably require mechanical ventilation with high levels of PEEP just to maintain basic oxygenation.
Following the respiratory collapse, the cardiovascular system begins to give out under the strain of massive vasodilation and myocardial depression from the inflammatory mediators.
And the hypoxemia in those same mediators cross the blood-brain barrier, leading to acute mental status changes.
Then the kidney sustains severe acute injury due to the prolonged hypoperfusion. Urine output trickles to a halt, creatinine climbs, and we have to be incredibly vigilant about any nephrotoxic drugs we're administering.
But the most insidious failure might actually happen in the gut.
Wow, really?
The gastrointestinal tract is extremely sensitive to hypoperfusion. Mucosal ischemia sets in rapidly, which causes the gut's natural protective barrier to break down.
And when that happens, the normal flora, the bacteria living in the gut, they translocate straight into the bloodstream,
essentially pouring gasoline on the systemic inflammatory fire. Simultaneously, the liver begins to fail.
It stops synthesizing albumin, which severely worsens the third spacing in systemic edema, and it loses the ability to clear the mounting lactic acid.
And if all of that wasn't catastrophic enough, the final domino is often the hematologic system, disseminated intravascular coagulation, or DIC.
The body's clotting cascade goes completely haywire. It starts aggressively forming microthrombi in all the tiny vascular beds, consuming every available clotting factor and platelet in the process.
It is a consumption coagulopathy. Because they have depleted all their clotting factors forming these microscopic clots, the patient suddenly starts bleeding uncontrollably from every other site.
You'll see blood oozing from their IV lines, their Foley catheter, their endotracheal tube. It is a horrifying bedside reality.
Escalating care for a patient sliding into MODS requires incredible multidisciplinary coordination. We're aggressively supporting failing organs while trying to optimize tissue oxygenation.
Because they are in a hypermetabolic state, protein-tolerant malnutrition is severe. We have to start early enteral nutrition, just trophic feeds into the gut within the first 24 hours, specifically to maintain that gut mucosal integrity.
And prevent that bacterial translocation we just talked about. We also maintain strict glycemic control, keeping glucose under 180 to reduce further inflammatory stress.
Let's hit the 5 things for SIRS and MODS.
1. Core patho. Unchecked systemic inflammation leads to diffuse endothelial damage and microvascular thrombosis.
2. Key finding. Worsening PF ratio as the lungs fail first, followed by rising creatinine and altered mentation.
3. Most dangerous complication is MODS, carrying that 40–60% mortality rate.
4. Priority nursing action. Vigilant assessment to detect early signs of new organ dysfunction.
And 5. Most important treatment. Early goal-directed therapy to prevent SIRS from progressing and enteral nutrition to protect the gut.
So if you see bilateral fluffy infiltrates, new bleeding from IV sites, and dropping urine output in a patient with a known insult,
think SIRS progressing to MODS and DIC, and aggressively support failing organs while optimizing tissue oxygenation.
The intensivist mindset here isn't just reacting to the alarms, it is anticipating the physiological dominoes. You identify the failing physiology, recognize the immediate threat to life, implement your intervention, and then obsessively reassess to see if you actually altered the trajectory.
It really is a masterclass in clinical vigilance. The difference between life and death in these states isn't just knowing the names of the drugs, but understanding the microscopic battles happening in the tissues.
I want to thank you for breaking down this incredible complexity into actionable bedside priorities.
It is always a pleasure to dig into the mechanisms. When you truly understand the failing physiology, the bedside interventions just naturally make sense.
I want to leave you with a final thought to ponder as you head into your next shift, based on the literature we reviewed today. We spent an enormous amount of time and resources in the ICU trying to artificially support the macro systems of the body. Titrating aggressive vasopressors, managing mechanical ventilators, placing cardiac pumps to force the heart to beat harder during shock.
It's all very macro.
Right, but knowing that the gut microbiome begins to break down, translocate, and actively poison the bloodstream the exact moment it loses microscopic perfusion. Could the future of surviving shock actually lie not in stronger vasopressors, but in discovering how to protect the microscopic bacteria inside our stomachs? Think about that next time you are hanging a bag for a trophic tube feed.